presenting a case of recurrent thyroglossal duct fistula after previous surgery. This case about 28-year female with recurrent thyroglossal duct fistula following surgery for thyroglossal duct cyst during childhood. This X-ray showing there is central body of hyoid bone was not removed during previous surgery at the time of 8 year of age. This sinogram showing about 8 centimeter length of the tract which is going up to the foramen cecum from the mid level of the neck. This patient noticed a small opening in lower neck approximately 10 years ago. Initial there was intermittent serial discharge. Over time it became recurrent with occasional mucopurulent discharge. Discharge increases during upper respiratory tract infection. There is no dysphagia, no odinophagia, no breathing difficulty, no change in voice, no neck swelling, or no history of thyroid dysfunction. On past history, she has having underwent for thyroglossal duct surgery at the 8 year of age. Detail of surgery is unavailable and there is no history of diabetes, tuberculosis or radiation exposure. Neck there is about 1 centimeter diameter opening is there with scar tissue which going up to the level of cricoid cartilage. Then I have to plan to cosmetically remove this scar as well as do the proper surgery in this case. There is moderate movement on the protrusion of tongue with swallowing because of previous surgery scarring. DD may be recurrent thyroglossal duct fistula, dermoid sinus, infected epidermoid cyst, branchial fistula, persistent pyramidal lobe sinus. All these are rare and this is already diagnosed case with sinogram and previous surgery. So it is a case of recurrent thyroglossal duct fistula. So after proper workup, I plan for extended Sistrunk procedure because this having en bloc removal of recurrent tract, central portion of hyoid, medial strap muscle, midline infrahyoid soft tissue till the thyroid isthmus, and most importantly, superior dissection towards submucosal tongue space that is called posterior hyoid space. So you have to dissect between the hyoid body and the thyroid membrane. This thyroid membrane is not going up to the hyoid bone only, it's going up to the base of the tongue. You remember this posterior hyoid space, and in this thyroid membrane extend up to the foramen cecum. So you have to dissect between the hyoid membrane, this thyroid membrane, and the hyoid body, so that you have to remove complete tissue between this, so that there will be no recurrence. In this case, I put two incision because of previous scar surgery in the lower neck, and second one to go into the posterior hyoid space. So this is step ladder extended Sistrunk operation. Recurrence usually occur because of incomplete removal of tract, failure to remove central body as this case, residual suprahyoid duct or less dissection in the posterior hyoid space, and there is multiple duct branches. Previous infection in scarred operative field may lead to this recurrence. In recurrent cases, a wider en bloc resection, extended Sistrunk provide better disease control than repeated limited excision. During development, this thyroid tissue develop from the lateral or median inlays from the foramen cecum and it descend in the neck. During this procedure, sometimes this persistent of thyroglossal duct form the this fistula or cyst and sometimes form the pyramidal lobe. So the dissection focus between the thyroid isthmus and the foramen cecum that execute the complete dissection of the tract and branching. Most common congenital midline neck mass is the thyroglossal duct cyst that moves with swallowing and tongue protrusion due to the attachment of the hyoid, tongue base and the hyoid bone and tongue that lead to the protrusion on tongue and the swallowing movement. Gold standard surgery for primary thyroglossal duct cyst or fistula is the standard Sistrunk procedure, and if recurrent, then you have to do extended Sistrunk procedure. There is four type of common surgery in thyroglossal duct cyst. First is excision only. You have to excise the tract only till the hyoid bone. Then second is the slaying procedure. That include excision of the tract with including the central body of the hyoid. Then third one is the cyst trunk procedure. That include you have to resect the cuff of tissue up to the foramen cecum from the hyoid body with the central body of the hyoid. That is called standard cyst trunk procedure. Then come fourth is the extended or modified cyst trunk procedure. That include dissection start from the thyroid isthmus till the foramen cecum with cuff of tissue around it and central body of the hyoid. That is called extended or modified cyst trunk procedure. Most common cause of recurrence in this case is the incomplete excision of the duct and central body of the hyoid. Most common malignancy arising in thyroglossal duct cyst is the papillary thyroid carcinoma. You have to remember this MCQ. Most common malignancy is the papillary thyroid carcinoma. If you compare the all four classes of surgery, first is excision, that is having recurrence about 50%. Second one is the slaying procedure, that having recurrence about 30%. Third one is the standard cyst trunk operation, that having recurrence about 5%. And fourth one is extended or modified cyst trunk operation, that having recurrence about less than 2%. Normally this surgery can be done with single incision, but this tract is very long, about 8 to 9 centimeter length, so I have to put two incision because of length, and second one because of scarring of previous surgery in lower neck. So I have to put two incision, that is called step ladder two incision with extended cyst trunk operation. Now I am putting second incision at the site of the hyoid bone. Now after dissecting this second incision, I will pull this tract from the that incision and I will work for the hyoid body removal. So this surgery start from the thyroid isthmus and identification of the thyroid, and that lead to second incision in the neck for the central body of hyoid removal and further dissection for the exposure. Now I am dissecting this. You can see in this video second incision to go up into the neck till the foramen cecum. So you can see the previous dissection incision. Now I am pulling this tract from this incision. Now I will dissect the hyoid body central part, and I have to take about 1.5 to 2 centimeter part of the central body of the hyoid, so that this tract, most of the cases, about 60% of cases, this going below the hyoid body or adjacent to the hyoid body, and 20% cases it's going from the center, and about 10% of cases it can come superior to the hyoid bone. So you have to look all the aspect of anatomy so that you can go through proper dissection of this hyoid central part of the hyoid body. There is no major structure till the lesser corner of the hyoid body. So don't hesitate and dissect properly in the hyoid bone, and you have to dissect first superiorly so that you can make the border superior border of the hyoid bone. Then you have to dissect laterally till the lesser corner, and after dissecting both sides you can put the uh, elevator, periosteal elevator, for making posterior space in the both side of the hyoid bone. And after making space you can cut the this bone both side with the nibbler, bone nibbler, so that you will gap the space posteriorly in the posterior hyoid space. So after elevating all side this tissue, now you have to make incision in the both side of the hyoid bone. After elevating by periosteal elevator on the both side, now you have to cut the bone. Now I am using elevator to elevate on the left side, then I will elevate on the right side. After elevating this, I will cut this central part of the hyoid body with the bone nibbler. After elevating posterior side, I will cut with the bone nibbler. If you talk about this complication of thyroglossal duct cyst itself, if you are not operating, there is repeated infection, there is persistent sinus discharge, there is abscess, arrhythmia, and rarely may lead to carcinoma formation. So, in primary cases, even though it is asymptomatic, you have to operate this sinus because it may lead to rarely for the carcinoma. That is most common carcinoma is papillary thyroid carcinoma. And surgery complication are recurrence is common in excision cases. There is seroma formation, hematoma formation, infection, and very rarely may lead to most common nerve injury in this case is the very rare hypoglossal nerve injury that is close to the lesser cornu and superior laryngeal nerve injury that is far extent from lesser cornu even though it may damage if you dissecting far laterally, and scarring is the common complication. You can see in this case scar was large in the mid neck in this case. So consent for this case like bleeding, wound infection, seroma, scar formation, persistent wound discharge, recurrence of fistula or cyst despite surgery, injury to nerve, most commonly hypoglossal and superior laryngeal nerve, causing tongue weakness or voice changes, injury to surrounding structure including thyroid gland or larynx, difficulty swallowing, pain during swallowing for short period, neck pain because of this movement or movement restriction in this case because of flexion position, need for further surgery if recurrence or carcinoma will be there, risk related to general anesthesia, and these are the common complication consent you can take in this case. After resecting the central portion of hyoid, now you can see tract going in the foramen cecum toward the hyoglossus muscle. So you have to take some portion of the hyoglossus muscle on the both side. That include complete surgery, and you have to take. Now you can see level of foramen cecum around this tract. So I am taking some portion of the hyoglossus muscle with the tract, which is going inside the this inside the foramen cecum. So now you can see the level of the tongue base. Now this tract is white and muscle is the pink on this tract resection. Now you can see I am resecting it from the foramen cecum level. After that I will cautery the base so that there will be no chance of recurrence. And after that I will put PRP with streptomycin powder in this case. Advantage of PRF and PRP in this case, it increase wound healing by acceleration of soft tissue healing by releasing growth factor. Second one is revision surgery, may improve healing in scarred operative field with recurrent TGDC surgery. Third one is dead space management. PRF membrane can be placed over the surgical bed to support tissue approximation. Reduction of seroma may reduce seroma formation because of dead space filling. Infection control. As you know, this PRP having leukocytes may, may having antimicrobial or anti-inflammatory effect. That and last one that induce the scar quality or that better cosmetic scar maturation will be there by this PRP application. Some studies suggest there is a reduction of postoperative pain and inflammation in the PRP applicated cases. That's why I will put the PRP in this case. Recurrence usually occurs because of incomplete removal of the tract, failure to remove central hyoid body, residual suprahyoid duct or residual dissection in the posterior hyoid space, and multiple duct branches, previous infection or scarred operative field may lead to recurrences. So in conclusion, recurrence or complex cases of thyroglossal duct cyst or fistula, surgery of choice is the extended or modified Sistrunk operation that include dissection from the thyroid isthmus till the foramen cecum with supra or infraord cuff of muscles around the fistula tract with excision or meticulous dissection in the posterior hyoid space till the post this thyroid membrane that include the complete surgery for this thyroglossal duct fistula or tract, and this is the complete surgery, and this is almost unedited video for this case.